and peer supporters that are participating if they want to elaborate on their experiences and make additional comments. I don't know why there's answers to this because we haven't asked it yet. Oh, can we wipe the answers so that we can actually do it? Give a second and see if we can do this. Worked so well so far. Perfect. Okay. So the question. Okay, I guess people are answering it, but I'll read it quickly. The question is, what, if any, tools do you use as a management approach for treating depression? Select all that apply. So you can do multiple answers here, one at a time. A, peer support. B, talk therapy. C, medication therapy and or dietary supplements. D, medical devices such as TMS, neurostimulation, electroconvulsive therapy. E, diet, sleep, physical activity, meditation, mindfulness, and other non-clinical approaches. F, personal wellness plan. G, other. And H, I don't have a management approach to treat depression. Yeah, you put put a letter and then send, the next letter and then send, the third letter and then send. I don't really understand why sometimes they decrease. I get that they're increasing. That's true, the percentages change, okay. Right. As more people weigh in. Okay. I want to wait long enough till they're sort of stable, but not too long. All right, I'm gonna, you can keep going if you want, but I want to focus in on the medication therapy. About 25% of you shared that you use medication as a therapy for treating depression. And so we're going to have another question. It's a fairly complex question. FDA asked us to ask this question. And we're going to ask about the medications that you might take to help treat depression. So I'm going to click to it. So there are 29 different medicines approved for the treatment of depressions. Their names and their classifications can be confusing and overwhelming. Medications approved for other conditions might also be used to help depression and symptoms and conditions that commonly occur together. And we've included some of them here. So we're going to give you just a couple of extra minutes to look at the list, which includes brand medication names as well as some generic names. If you don't see the name of the medication you take, please check other. And you can select all that apply. And again, you type in A, B, C, whatever. And I'm not going to read all the names. For one thing, I probably can't pronounce them all. But the question is, if you take medication to help treat depression, which of the following do you currently take? A, I don't take medication. B, SSRIs, and you can see the names of them listed there. C, SNRIs. D, atypicals. E, tricyclics. F, MAOIs. G, other. And H, I don't know. Okay. Right, thank you for your responses to this. You can see how how the responses fell out. We are going to sort of set this aside, but it will be useful, I think, to the FDA and to see what generally you're taking. We're going to take a deeper look at the complete list of management approaches, other than medication, in a few minutes. But for now, we're going to move on. supporting wellness survey, in response to a question about the number of discrete periods of time when symptoms significantly affected their lives, 2/3 of respondents indicated that symptoms are either persistent or that they've had more than 10 discrete periods. You can see what the results showed in the survey. So in our next polling question, we want to understand how you manage the symptoms. And we're going to do that with just one more polling question. During the time when symptoms impacted your life, what, if any, adjustments did you make to your management approach? Choose all that apply. A, increase peer support. B, increase talk therapy. C, work with my clinician to change my medication therapy. D, work with my clinician to incorporate or change use of medical devices such as TMS, neurostimulation, electroconvulsive therapy. E, made changes to my diet, sleep schedule, physical activity, medication, mindfulness, or other non-clinical approaches. F, I didn't do anything different. G, I don't know. And H, other. Okay, so what I want to do now is delve into this a little bit by talking, to you all in the room and giving you all a chance to comment on it. DBSA staff have the microphones. If you're participating via the web broadcast, type your comment into the comment section. And to start, I'd like to focus on the top two responses. So let's work with made changes to your diet, sleep schedule, physical activity, medication, mindfulness, or other non-clinical approaches. What did you, how did you do that? Anybody who answered that, would they like to comment on it? There's one over here too.
Starting in January of this year, I really started to try to incorporate as many different holistic approaches as I could to try to keep myself balanced. So meditation, yoga, my diet, I went from virtually vegetarian, almost entirely vegetarian. Essentially, if it's made somebody else feel better or if it's worked for somebody else, I'm willing to try it. Because as somebody who manages bipolar disorder, there hasn't been an antidepressant that has worked for me whatsoever. I only take a mood balancer. So I have to turn to these other methods to try to keep myself as happy as I possibly can be. And it's worked really well for me. It takes a lot of effort, and you have to keep on adapting and keep on putting things into your daily routine to do it. But it's really been the only effective treatment for me as far as depression goes.
Good that it's been effective. We have one right here.
Hi, I'm Lucinda from DBSA Boston and DBSA National. So I find it really telling that so many people, following on this previous speaker, take on lifestyle changes and other practices. And personally, actually doing all of those things, and probably being also postmenopausal, I also have experienced mania and depression. I take very little medication, and I only take the medication because I promised my parents I would, and it's an integrity issue. And my psychiatrist and I have virtually gotten it down to nothing. The other concern that I have in terms of our conversation today, and it may not fall within the bounds of the FDA, but there was an article recently in the New York Times, it was in the last week or so, that pointed out that it's called What's Like After Depression, Surprisingly Little is Known. And there are actually people, as you saw in the even our data, where I'm assuming mostly people who have depression or are affected by it negatively most often are the ones who answered our survey. But there are people that actually do not have it forever. And the fact that we have no data on them, longitudinally or otherwise, is, I think, a great omission. And coming from DBSA, where we have a strengths and resiliencies model for living with mood issues, it's a place that I think the medical model needs to go. Because if we could understand why some people are able to either get over depression or live with symptoms or live well with symptoms or without symptoms, we need to know what contributes to that. And perhaps if we knew what contributed to them, we'd be able to create protocols that would help people that are at the affect of it most often. So thank you.
Thank you. Kim? Yep. Okay.
You asked about the making changes to diet, sleep, etc. And I know for myself, when I feel sort of that undertow coming on, those are things within my control that I can do on my own before I can get to a therapist or to my doctor or get, in on some of the other things. So that's kind of my first line of response. And I wonder, in terms of therapeutic intervention trials, how much those things are controlled for, given that, it's the biggest bar, and it may not be anything that is being necessarily monitored or collected as you're looking at whether another type of therapy is effective or not. And it could be differences that are occurring in some of those other things that we're not even asking about.
That's a very interesting point about how do you control for the fact that, while at the same time you may be starting a new medication, you'd be doing a lot of other things too and get control. I think we heard Patrick talk about what a big difference it made when his daughter sort of altered her lifestyle and sort of took responsibility for making sure she got enough sleep and was eating well and things like that, and how that affected it.
Hi, Legini Bailey. I'm from DBSA National. I'm a family member, and my brother died when I was 18, and I walked in on a suicide attempt from my parents. So one of the things that I know, that fever of unbelievable hypervigilance that creates a level of anxiety in a caregiver. I've been a 20-year meditation practice person and have gone with meditation techniques that have scientific validity and mindfulness, MBSR, looking at other forms of meditation, iRest, extremely, extremely helpful in managing that level of hypervigilance, both in patients and caregivers. I always say I have a 3-day half-life for meditation. If I don't do practices that make a difference every 3 days, it helps abate any of that hypervigilance. It's very, very important. Also, diet and exercise, critical to bathe the brain in things that are going to give neural resilience. So.
Thank you very much. I think several of you have touched on the role that peer supports, family members, and others help you in making decisions about how you might manage your condition. Go ahead.
Hi, I'm Barry. I'm a family member, and one of the things that I've observed is that, when someone's in deep depression, just even getting out of bed is, virtually impossible. And I've observed that sometimes there are techniques that people have used that are probably not super healthy to kind of jumpstart or kind of knock them out of that. For example, it sounds bizarre, but hitting one's head against the wall or against the floor creates a pain response that has generated some sort of stimulation that has helped get them off their feet and moving. And so from a therapy development perspective, because exercise, diet, all that stuff requires motivation that depression itself saps you of. So it's a nice idea, but it doesn't work if you can't do it. So that from a therapy development perspective, my idea is I've wished that we could have something that could help kind of jumpstart or get us out of this that moment so that we can get to a spot, even if it's just a temporary thing, get to that spot where they can then get back into a healthy routine. And and I think there are other conditions where there's a similar kind of concept where if a patient is not doing well, clinicians will infuse a drug, for an immediate response to get them back to a point where they can then treat them better. And obviously there's a potential for abuse if it's something that's super, super effective at picking you up. But that to me seems like a big hurdle for depression because it's just got this momentum that's hard to get through.
That relates to a question of, how concerned are you that you will be, that you're going to reach a point in your life where you're unable to manage your symptoms, nothing's going to work, and that you will not be able to achieve the health outcomes that you desire, and what effect. Have you ever experienced that? Are you concerned that you're going to get to that point?
Hi, it's me again. For me, the increased peer support, where that comes in, is twofold. When I'm in a bad place, so to speak, I tend to increase the amount of peer support that I offer to others. This helps me tremendously. It gets me out of that place in my head. It gets me where I can take the energy, I find the energy in myself to lend that energy to somebody else that is in a worse place than I am, if we want to use those terms. So that's one of the most important things that I've learned over the years, is to get out of my hole and to offer to somebody else that through what I've learned over the years, that by reaching out to others, even when you think you don't have it in you, you don't know, there might just be one word that you offer to somebody else, and that one word could be that turning point for them. And that one word could just be care, or I care. That's what I do.
Thank you very much. That's a very powerful message, I think, to hear for everyone in the room. Or just anybody have anything else? Because I have one more question, but then we have to move on. I just want to know, does anybody see any options for managing depression that are not on the list or that you'd like to see developed?
This may not speak directly to that, but with this age of drug abuse and addiction and all those things, I have insomnia. It is just, it's so bad. And when I don't get enough sleep, then I'm not able to deal with all my other symptoms. But my doctor has told me he must cut me back on Ambien because it's not a good drug to be taking, or he gets more points or something for taking his patients off the medications like that could be addictive. I've tried, over the years, I've tried almost everything. I do meditation, I get out of myself, I do peer support, I do all those things. But the insomnia is real. It's not just you don't go to sleep at night. And there's something that will help us sleep, or not the worry about becoming addicted.
Thank you. I think several people have mentioned sleep disorders of various forms. That really, whether you sleep really affects how you feel and your overall health, I think. So unless there's anybody, I'd like to move on now to the next one. I want to talk in some more detail about some of your unmet needs. I think that one of the most important aspects of this is what are your unmet needs, and what would you like to see in terms of treatments, and particularly treatments that drugs can be used to address. Um, so as you can see, some of the other aspects of wellness that were important to peers responding to the supporting wellness survey included having a purpose in life, getting through the day, self-acceptance, follow through on ideas and intentions, calm and relaxed presence. So I'd like, given that the survey respondents shared that this list represents important aspects of wellness, we'd like to understand why some of these aspects are important and how you would personally evaluate whether or not you're attaining wellness within these aspects. So first of all, I'm going to start with getting through the day. Some of the respondents to the survey stated that getting through the day was an important domain of wellness. What does that mean to you? How would you describe it? And can you give some examples of what it means just to get through the day? Anybody? There you go. Maria?
Well, everything fluctuates throughout the day, and in between anxiety and depression, it is not uncommon for me to walk down the street and just objectively say to myself things that I see: podium, person, table, white, black, carpet, just to stay present. And that is one of my most useful tools to get to the train and not think about stepping in front of it, or to get me to home, to get me to make dinner, to get me to text my friends that I love them, to get me to listen to 3 guided meditations that'll get me to sleep. So.
Thank you. Anyone else want to address that? If not, okay, so I'm going to, Keith, when he was up here, shared about how it can be difficult to follow through on ideas and actions because depression had immobilized him. Anybody else have examples of that or want to share any experiences with that?
I'm going to speak on behalf of my 19-year-old. He has all these great ideas and intentions. He comes downstairs and tells us, he's going to be get into music management, or he's going to be the next this, or he's going to go to school to get into HVAC. And he'll be talking, and I can see him just shut down. I see just that you can just see him just completely shut down. And I think he realizes he has this depression and he has this anxiety. And it's all he can do to even come down and tell me about these great ideas before he just shuts down and goes back upstairs and goes to bed.
Yes, what do you do? What do you do about that when he does that?
I go upstairs and I stare at him until he talks to me. He says, "Mom, I'm very uncomfortable with you in my room." And then I bribe him with pizza. Pizza gets him out of bed. Pizza gets him in the shower. I mean, I do the best I can do. But yeah, it's hard to watch him just completely just shut down in the middle of something.
I think for me, follow through, and I'm going to speak from my mother's responses. I tend to be just by nature, a big idea thinker. And I like broad policy and all those kinds of things. And when I have this conversation, my mother goes, "Is that your mood disorder?" And I find that very often when I'm sort of a Bill Clinton, I just talk out loud until I come up with an idea that sort of things fall together. And very often I find that it's almost like, how dare you? You're getting sick. This must be about being sick, when in actuality it's about being well. And that every idea anyone has doesn't mean it's going to happen, but to be able to brainstorm out loud. And very often find that even this idea of getting through the day, some days I can make my commitment and some days I can't. And I talk to my support system and say, "How are you feeling today?" They're like, "It sucks, it's Monday and it's raining." and that's a normal response. So I think that that idea of the follow through, I often have to check in with other people to say, how are you feeling? To see, are my feelings normal or not normal? And how much energy are you giving to your job? Is it normal? Is it not normal? But yet, I find it very challenging when my mother sort of says to me, there's that mood disorder again. I love my mother.
There's another one. No, there's another couple of, okay, so over here first and then over there.
So you talked about your interest in being immobilized, and I'm going to represent someone who's a leader and a book author whom DBSA National invited to speak as its voice 2 years ago at a DBSA National conference, and that's Andrew Solomon. Andrew Solomon sort of shared with us first that people tend to think that the opposite of depression is happiness. He said the opposite of depression is energy. And that was a very powerful experience for everyone in the room. And then he followed that through with a discussion about his own immobilized state. So anyone who understands what Andrew Solomon has accomplished in his work for the New York Times, in his book on depression, The Noonday Devil, on his powerful book, Far from the Tree, you know that in periods of his wellness, he's extremely productive. And yet what he shared with us at DBSA National that day was a conversation about how he had to call his father to help him get out of bed because it was so painful to make it to the shower and actually turn the handles. He had no energy. So I offer that to you on his behalf in what he would say about immobilized moments in depression, and also what he thinks of as a better kindred opposition than happiness.
Thank you, that's very helpful.
So thank you everybody for sharing the different aspects. I think one of the most helpful for me coming out of therapy and then the mindfulness training, I always think of it that we don't use brain training enough in psychiatry other than CBT. However, so mindfulness, therapy, and also transformational personal development courses that I take have really enabled me to separate my mind and my thoughts from who I am, and that when I act from who I am, then my mind and the thoughts that I have can just be, you know, thank you for sharing you're feeling depressed today. Thank you for, you know, sharing that you suck and the world is terrible. I mean, brain, fine, share what you need to share, but I'm going to go out and do what I said I was going to do. It doesn't sound like, well, how do you do that? It's an experiential training, and I think you'll find, like Eckhart Tolle talked about that. He was suicidal when he had his moment of revelation, and as we all know, he's become a spiritual master out of that. Is everybody capable of this? I think so. I was just lucky that I found the right combination for me to be able to do that, but I don't think it's something that's exceptional, and I hope someday we're able, again, to study things of this kind, to give people access to the power of their own minds, to change how they relate to it. Thanks.
Thank you very much. So I would like to, that is actually a really good segue to the next topic. But before I go there, I just want to ask if anybody has any other aspects of wellness that they think should be added to the list that are not here. I think it might be important for people to hear. If there's something, if you could just make your comments very brief.
I studied what they call imagery, and I noticed that it's not as open as it is today. And imagery was one of the powerful things that helped me through my experience of depression. And I was hoping that imagery and family therapies with it could be added.
Thank you. Can you hear? I don't, yeah. Okay. I think that would be one of the things that you might want added to one of the other lists because of the things that people might use to manage depression. So I'm going to, anybody else, I'm going to take advantage of that segue because into how do you measure what people are thinking in their brains to tell what the results are. So we're going to shift gears now and get your thoughts about the scales that are being used in clinical trials to measure the effectiveness of medications. When they are studying the potential clinical benefit of a medical product in a clinical trial, they use scales and measurement tools to assess change that might indicate how well a medicine or a device is working. Sometimes these are also used by your doctor to assess whether therapeutic therapies are beneficial. And traditionally, these measures have been based on the clinician's observations of how well the patient's doing. So a number of companies have collaborated to develop a new scale that FDA recently approved for exploratory use in clinical trials. And Dr. Mathis, I think, and Dr. Saxby have also mentioned this as well in their remarks. And FDA has specifically asked us to gather your input on the aspects of depression that this new scale is designed to measure. So I'm going to ask you some general questions about the new scale, and then I'm going to show elements of the scale and drill down a bit to get your reactions to the specific elements and the measures that they're going to use. So we're getting very close to the end of our time, and we'll only have time for a few comments on these. So if you could please try and keep your answers brief. Okay, so my first question, I'm not going to turn to the scales yet. There'll be two more slides that talk about the scales. But first, I want to ask the sort of broader question of, do you see advantages to having the patient report the clinical benefit rather than the clinician doing so? And if so, why? You know, what are the advantages, and why do you think that? So that's the first question: is the switch from a clinician-measured outcome to a, I'm going to use the word patient here because they would be a patient if they're involved with a doc.
I think it's a mistake to phrase it as an either-or question. I think I've watched my daughter bullshit numerous therapists over the years, pardon my French, but the therapist was able to understand the help that she needed when my daughter was very capable of masking that. So I think that there really needs to be some cooperative assessment there, because it takes a certain amount of self-awareness to tell someone how you're feeling in an effective way. And if you're in a bad spot, you may not have that. So that may be the first thing that is important to keep in mind.
I think it's a very good point.
I agree with what the gentleman just said. It absolutely has to be a combo platter of the two, but it is essential that the patient express how they're feeling, because there's no way that the doctor can quantify motivation. And as we learned from our gathering last year, that's really one of the big...
you can hold the mic closer. So.
That's really one of the big things that can show if a medication is working, is if the patient feels motivated. And when we looked at the questions that the patients were being asked last year, there didn't really seem to be any way to judge just through those questions the motivation factor. So yeah, I do think that the patient needs to have definitely some input.
Does anybody have, well, we're up there, go ahead.
I can't remember the name of the doctor who's the director of the center.
Dr. Mathis.
Yeah, thank you. He had listed on it was hard to read, but they listed other outcome measures, I think, and one of them was a third one, which was actually other people around the patient, like family members. And the woman who mentioned, who loves her mother, that might be a good thing. That might be a good thing. That could be a bad thing, in some respect, from a caregiver perspective, being the person who's kind of tattletaling or watching a patient or a loved one kind of like a hawk. Oh wow, looks like they're not getting a lot of sleep. I better somehow report that. That's not necessarily a healthy relationship, but somehow capturing there's other people involved in it. It's in my case, I believe it's a family disease, and having other people be able to kind of provide some sort of way to get feedback. Because again, I mean, to the gentleman's point, my wife, I'm pretty sure, lies to her therapist every time that they talk. And not that I want to be the guy who's like, no, she's full of it, but I think it'd be good to have almost a three-way perspective on the condition.
Yeah, I'd say everything needs to be combined. I had the problem that when I would go to doctors, in particular new doctors, I presented very well. I was well educated on this. I had the right words to say. I made jokes, and I could not get across to the doctors how bad my depression was. And I think to some degree, especially maybe in a new situation, there might be an inclination to think that maybe I was exaggerating or something. And literally, I had been to my therapist for years before he understood when I left a voicemail for him when I was really bad. And he had not understood it, speaking to me for years. There is also the problem with reliability of self-perception. Because when I would go into the psychiatrist and say, how was the month? If I was in a bad mood, I'd say, oh, it was awful the whole time. If I was in an okay mood, I would say, it was kind of bad. And it wasn't until I was able to go in with mood charts and we could count the number of days and count the severity that we could understand. And it wasn't until I could go to a psychiatrist and say, scale of 1 to 10, I'm an 8. And see the psychiatrist just be completely surprised that was my reality. So I would definitely say a combination.
So, okay, one more, and then we're going to get into one of the more general questions. Then we're going to get into the scales specifically. I'm going to show you the scales, and I want to get your reactions. Go ahead, Yvette.
I think we also need to be thinking about how people are trained. I'm a clinical social worker, and I go to a psychiatric nurse practitioner, and my treatment with her is better than my treatment has ever been with, that's a lie. I have one psychiatrist that sort of matches her. I have a lot of psychiatrists. But I do think we need to be thinking about other providers, be them physician assistants, other people who are in positions to prescribe meds, but also the way that they're trained is that it's not a 15 in and out, but that it actually has a therapeutic piece attached to it. And so, I think we don't think about that enough.
More.
Yeah, just really short. I agree with most of the comments here. Once I had a chance to look at surgical notes after surgery, and the first thing the surgeon mentioned was she has a pleasant disposition, and and so that's just naturally my personality. I'm always smiling, but my pain was likely a 10 at that point. So it's it's really important to have input from from everyone, including caregivers and the patient at at every given chance.
Okay, thank you. So now I want to talk about the time period of observed change. We have had several people mention that 30 days isn't enough. We want people to look for the long term. But this question is really about the time period of observed change. And traditionally, the time period of observed change is over 30 days. But the scale that they've developed asks the patient to reflect back only on the last 7 days. So sort of separating out from whether you're measuring long-term impacts or not. The issue is if you were going to be asked, how did you feel over the last 30 days where your mood may have fluctuated considerably, but now they're going to ask you to look at the last 7 days. What do you think about that? Do you think that that's an appropriate time frame for you to sort of look at and measure how you're feeling?
I don't think you can capture enough information. I'm also concerned, even in the 7 days, I like the idea of having someone maintain a chart because you just don't remember. And whatever mood you're in on that day that you present is going to definitely impact your overall assessment. So I think it should be certainly longer than 7 days, but more of just me reporting to you, looking at some sort of measure.
So it might be a question of how often you did it. Let's say you did it 4 times in a month. You know, what did you feel for this 7 days, the next 7 days, the next 7 days, as opposed to seeing you once a month and saying, oh, how did you feel over the last 30 days?
I do charting and actually do charting around, and one of the things I realized with both myself and also with my patients is that when they're not charting is when I know they're not well. So I think that we also need to be mindful of sort of what does that mean or not mean, and that what we think it means may actually be just the opposite of what it is.
Thank you. So, Kevin, you have something from the web?
Yeah, 2 people had mentioned online that they actually use the DBSA wellness tracker to be able to keep track of their moods. And another person who's in dialectical behavioral therapy uses an app to be able to keep track of their moods and feelings. So there's different things on different apps to be able to allow that.
Thank you. And thank you to the people on the web who are making comments. I think it's helpful. Anybody else?
I just want to bring up the problem of hospitalization in this conversation that we're talking about now about time. I'm a senior administrator at a therapeutic day school in Manhattan, and I can tell you that that the bar at the moment medically is if one is at imminent risk to oneself or others. That is a very low bar, and it is extremely limiting. And so any number of really fine physicians, psychiatrists, professionals who are clinicians in New York will tell you, don't go to the hospital unless you're absolutely in that position because you're going to end up going home 2 days later or 3 days later. This is, I think, responsive to your point. If you look at 7 days, you have to understand if we're talking about a very significant number of the people who responded to this, so over 50% are young adults and who remember onset as adolescents. If you look at any of the indicators that you've already offered with regard to atypicals and many other drugs you've discussed, anyone who knows this world knows that it takes a couple of weeks just to find out, first just to get up to a therapeutic dose, right? Titrating up slowly for all the other components of risk you know. And so there's 14 days. And we haven't had a chance yet to assess what we're calling a therapeutic dose.
Okay, thank you. Okay, so now I want to move on to the specifics, a few more specifics about the new scale. So here's a list of the dimensions for the new scale. These would be rated as not at all, a little bit, moderately, quite a bit, and extremely. So the question is, what do you think about these questions and the way they would be measured in terms of reflecting how well you're doing and how well they would be likely to reflect any change in how you're feeling as a result of a new medical product? Take a minute, take a look at the list. And again, they would be rated as, each one you would rate as not at all, a little bit, moderately, quite a bit, and extremely. Think about if somebody put that in front of you or was asking you these questions and asked you to rate them, how would you feel about whether they would reflect how well you're doing and whether they would reflect any change that you might be feeling if you had just started to take a new medication?
This list overwhelms me. And if I, today on Friday, is it Friday? Whatever day this is.
Which is why it's a problem.
Yes, exactly. if I say, okay, the last 7 days, that's until last Thursday, Friday, Saturday. Well, I was sad on Thursday. I was hopeless on Friday. I was irritable most of those days. I have a very difficult time sort of figuring out which of these might be the most important for me to report on. Now, if you could give me, and Yvette's going to give me such a thing, a chart that every day I could say, I'm not very hopeless today. This is really a good thing. Or I'm overwhelmed, but I know why, and I'm going to get over it. And by the end of the day, I will not be overwhelmed. If I can do that on a daily basis, that does two things for me. One, it gives me a record that I can then share with my practitioner. It also tells me what I need to focus on. Because if I'm overwhelmed, it's almost always because I've said yes to too many things. And I just need to back away, and then I'm not tired. So I think it has to be an ongoing thing for me. That may overwhelm other people, but for me, I have to do this every single day.
Thank you. Anyone else?
I guess it also doesn't really get at the what people want aspect. We just heard all about all the different things people want in all those different ways, and I guess this describes what it might feel like to have depression, but doesn't have a relationship to what people with depression would want, based on what we've heard today. And I'll always put in a plug for NIH developed promise measure set has satisfaction with social roles and activities, which does kind of describe all the different domains and computerized adaptive and everything, and far less overwhelming. So I think something like that could be a lot better.
I can add to that and say when I read this list, it's almost overwhelming in terms of the negativity, and I felt like it could be framed in the exact opposite way, and it would tell us the same thing, and it wouldn't be overwhelming to read through.
I'm sorry, I asked to have the mic back for just a minute because I just want to do a plug. NIH does really wonderful work. PCORI, Patient Centered Outcome Research Institute, does amazing work because everything they do is patient-centered. It's all about, well, what's the patient feeling? What's the patient doing? What does the patient need? And NIH is a very scientific sort of study. But I think we need a little bit of both. And I really want to say Patient-Centered Outcomes Research Institute is really focusing on patients. Thank you.
I think question 7 sucks. I agree that we should be coming from an asset-based perspective. And if I'm thinking about my problems, my friends have more financial problems than I do. So therefore, and like I said, I'm constantly testing against other people, sort of how they feel, what's going on, can you concentrate, what's happening, are you overwhelmed? So I absolutely agree that we need to be thinking about flipping this to an asset-based perspective, but also, asking ourselves the question, what is, and this is the fun one, what is normal and what is part of the mood disorder?
Okay, we have one more. I think we can only do, well,
it's a quick one. Once again, the word motivation is missing from this list. When you're depressed, you're unmotivated. And so maybe number 10 could be, if we could add one more, how motivated were you today?
Well,
I was going to say uncompleted tasks.
Okay. One other, just.
Energy and resiliency.
Okay, that's great. Okay, thank you very much. I got another list for you, so hang on.
The one last thing I just wanted to add that sort of goes to that is flatness. I think that's huge.
Okay. All right. So here's the second list of dimensions for the new scale. Well, there's 10, 11, and 12, so we'd have to add the others as 13, 14. Well, that's the whole list. So these would be rated as never, rarely, sometimes, often, and always. What do you think about these questions in terms of reflecting how well you're doing and how well they'd be likely to reflect any change in how you're feeling as a result of a new medical product? Um, and I guess we don't have to repeat the same, comments about they are negative. They're framed in the negative, so we can skip that.
So I've never met anyone that feels like doing nothing. I think with depression, you feel like doing something all the time. The question is, can you? And or blaming yourself when bad things happen. I think it's really important to look at both sides of the experience.
I guess I'd like to ask if anybody, whether these dimensions that are here matter to you. Are some of them more important than others? Going back, I guess the question really goes to both, list one and list two. Are there any here, if they were written differently, which do you think would be the most important to you? Go ahead.
Yeah, the second slide. So I don't know if you have consulted with any eating disorders group, but that may be triggering like just asking about overeating. Perhaps saying, do you have increased appetite or something? I'm not sure, but that could be triggering.
So overeating might suggest that it's a bad thing, and someone with an eating disorder would react in a problematic way to that.
I noticed it especially with those two, 11 and 12, but they're value judgments. They're, poor, and they're not even balanced. Have you had to eat? Have you had a meal? Have you not eaten anything? Have you eaten everything? I mean, something where it's not you're deciding, oh, I'm being bad or I'm being good. But I think the sleeping one also would be helpful more towards the front than towards the back.
No, number 5 where it says, oh.
1 second. I just want to go back. Well, it relates to 6.
Yes.
Over the past 7 days, how tired have you felt? It sort of relates to the sleep thing. Okay, go ahead. Sorry.
Yeah, I was just going to say, and on number 15, it might not be blame yourself. It could be blame yourself when bad things happened, or it could be blame yourself because you are the bad thing. No, I'm not saying say it that way, but I do think that at times it's about if I was not the problem. So we've got to figure out how to word it differently, but I think that that's a question that could be helpful.
Kevin has some, before you get to another, can you wait 1 second? Kevin has some comments from some people on the web.
So the challenge that one person has online is not with the questions, but with the period of time. They're saying that depression is cyclical. So they could have a good period for 7 days, and then after that, day 8, they could be doing really bad. So it's a period of time that they have an issue with.
Okay, over here.
I just wanted to comment, basically 13, 14, 15, 16. I recently moved, it's been about 3 years, from Maryland to Pennsylvania. Needless to say, my upstairs is still in boxes. I find it very difficult, and I do have to push myself to get things done. Maybe it's more I'm just not happy where I'm at, but the majority of the evening when I'm home alone, I don't feel like doing anything. What rule of thumb I try to follow is just keep moving forward. Just keep moving forward and you will be okay.
Thank you very much. We have one more over here. I think this will be the last comment.
I've got
one. Shelby has a comment. Okay, I'm too soft. But okay, one here, and if not over there, then Shelby.
Okay, I'm
Okay,
just wondering with this, looking at this list, is this a list of things that we're going to keep to ourselves, or would we share this with others?
I don't know the answer to that. I think it would be a scale that would be used. Go ahead if FDA would like to. The mic's not on.
Okay. So there's a couple context pieces that may be helpful for you all. So this instrument was developed with input from patients throughout the development. So this was not a clinician-driven instrument. This was from patients. So there was some thought there. The idea is this to be used in clinical trial setting. So I think the question about would something be actionable based on your response, I think it's really to be used to support an endpoint in a trial. So that's one thing. And that, this is something that would be provided in a trial design multiple times. So it's not like an instantaneous, like, how are you today? Or in the last 7 days, you would be getting it on a cycle basis. So to be capturing my good weeks, my bad weeks, my in-between weeks. So the idea is to be used through a duration of a trial in that aspect.
Thank you so much for clarifying that. I think that's helpful. Shelby, do you have something?
So the question is there a daily diary concept of this? So actually that is a concept that is being explored right now. As we speak, the group that has developed this is looking into a daily and a now concept of how to use this work they've done, leverage, and then add what is needed to measure within 24 hours and then what is right now, because we do realize that those are important concepts as well.
Shelby's going to have the last word.
I just wanted to add one little thing because a lot of these are important, but for me, when I am struggling with my depression, I isolate myself from social relationships and I avoid commitments. And I didn't see a question that kind of addressed that, because when I am feeling myself falling into that deep, dark hole, I notice that I don't call my friends. I don't go out in public, so social interactions are decreased. So I think that would be important to add maybe.
Okay, thank you very much. So that really sort of brings us to getting close to the end of the program. I want to thank everybody here, the panelists, and everybody here for your participation and your comments. I'm sure that the active listeners in the room have found this to be invaluable. Now I'm going to turn it to